Hey guys, welcome to the second part of the Airway discussion or the Airway lecture. I think we talked ad nauseum, or we talked enough about the airway, some breathing components, and respiratory anatomy and physiology. So now we're going to move into the management and ventilation of patients requiring both. So the number one question we're always going to ask when it comes to airway, and airway is the first part or that essential part of the primary survey, is the airway patent? And airway patency is going to continue to be one of those questions that we will continuously be addressing during the assessment of our patient. So if the airway is patent, we're going to move on to breathing, right? So ABCs, airway breathing. And we're going to look for adequacy. And we talked in the previous lecture about assessing for adequate tidal volume, chest rise and fall, respiratory effort, rate, and rhythm. So again, just to kind of recap on the respiratory rates, the normal respiratory rates are for adults 12 to 20 breaths per minute, children 15 to 30, and infants 25 to 50. Once we've done the airway breathing part of that breathing piece, of course, is to move on to oxygen administration. It can be something as simple as a nasal cannula, 2 to 6 liters per minute, or a non-rebreather, 15 liters per minute. And it might even progress more, kind of depending on the case of the patient, to something along the lines of a CPAP, or perhaps even some sort of intubation. If the airway is not patent, the first thing we're going to do is position that airway using a manual maneuver. Right? The manual maneuvers we commonly refer to are the head tilt chin lift, or the head tilt chin lift, and the modified jaw thrust. Okay. Once we have used either of those two, right, and the modified jaw thrust is going to be for that patient that is exhibiting either a mechanism of injury, an index of suspicion, or we're not even sure one way or the other of a cervical spine injury or spinal injury, those will be those folks that get the modified jaw thrust. So we've positioned the airway with a manual maneuver. Now we're going to look into using an adjunct. And adjuncts are one of those pieces that I think get underutilized a lot in the field, particularly locally. And the OPA, or the oropharyngeal airway, or the nasopharyngeal airway, are two devices that we should be using every time we need to secure or help ensure the patency of an airway. Because professionals use the tools at their disposal. Okay, so we're professionals, so we should be using these adjuncts as needed to ensure patency. And as needed means if you're going to a more advanced maneuver, such as a back valve mask or an intubation, you shouldn't pass through OPA or NPA land without giving it a stop and giving them a shot. Okay, so a couple of pictures of a couple of different adjuncts, ranging from the very basic to the most advanced. And if you look at the photo on the left-hand portion of your screen, in the top left-hand corner, right, we've got the NPA moving clockwise to the OPA, the ET tube, the tracheostomy tube, the King LTD, and the combi tube. As we look into the right hand, right, we're looking at the oropharyngeal airway and where it's supposed to sit physiologically or anatomically speaking, and then the NPA and where it's supposed to lay anatomically speaking. Okay, so we've addressed the airway. We've done whatever we needed to be patent. Okay, so we've used our adjuncts. We've decided that the patient didn't have a patent airway. So we've made it patent through a manual maneuver. We have inserted either an oral or a nasopharyngeal airway, and now we're deciding whether or not we need to ventilate. So a lot of cases in the field will call for ventilatory support. And for instance, in that unconscious patient, the respiratory center may not be functioning adequately. And what is adequately? Well, we covered that in the earlier presentation. That adequately will be that they are respiring, or the respiratory center is able to produce a stimulus that is adequate to support the functions of life. Okay, so effective ventilatory support may be a tidal volume of 6 to 8 milliliters per kilogram of ideal body weight. So what is that? Right, that one's a little bit difficult to ascertain sometimes, because what is ideal body weight? As we know, more and more of the population is becoming more and more challenged by gravity and girth. But we still want to look at that rate of 12 breaths per minute or so. And that'll give us one breath every 5 seconds, right? Breath every 6 to 8 is not going to be that bad either. Particularly, we're still kind of looking in that maybe 500, 600. So if you have a 100 kilogram man, so 220 pounds ish, right, at 6 milliliters per kilogram for that 100, that's about 600 milliliters, which is right around that tidal volume that we're looking for that we discussed previously. Okay, basic airway techniques, right? We've got for ventilation, particularly. The first one, the O2 via non-rebreather nasal cannula, right? We've got the patent airway. The breathing is they are able to breathe on their own. They're within a limit that makes us feel comfortable with applying oxygen, supplemental oxygen via non-rebreather or nasal cannula. CPAP, some books refer to, or some texts refer to CPAP or BiPAP as a basic technique. We'll consider it kind of basic here, mainly because it's not as, invasive as, say, an extraglottic, supraglottic airway or ETI. Okay, so we've got the O2 via non-rebreather, CPAP or BiPAP, adjuncts, the OPA, the NPA, or the bag valve mask. One of the advantages of CPAP, at least anecdotally, is that since the addition of CPAP to the pre-hospital repertoire, we've been able to, I feel like, greatly reduce the number of nasal intubations or the need to knock folks down that are having that are experiencing that CHF. And by doing that, we're able to decrease the preload and afterload in that CHF patient. We're able to decrease the potential for infections. And it's going to be advantageous to ET intubation, particularly in that infection route where it's going to decrease that risk of secondary infection. Plus, it's not as traumatic to the patient as attempting to intubate them. Plus, for a lot of these folks, especially nowadays, they're becoming more and more accustomed to using that CPAP. And once they get in line with our program, they tolerate them very well, and we see really good outcomes. Okay. So if we decide, however, to ventilate that patient, right, we've got that patent airway, we've got the OPA, the NPA, we've had the head tilt chin lift prior to insertion of those two devices, and we want to create an effective seal between the mask and the patient's face. And, a lot of times I see that, one of the things folks do either in a lab setting or in a clinical setting is when we do a couple of things. One is there's times when we put the least experienced provider in managing the airway in the basic sense. So in that bag valve mask situation, we tend to use like the least experienced provider when it should really be the most experienced provider. The second piece I see, even in experienced providers a lot of times, is that we are placing the mask down on the face, pushing the face or the head out of head tilt chin lift or jaw thrust, instead of maintaining that head tilt chin lift orientation, applying the good CE technique for applying the bag and bringing the patient's face to the mask, not the mask down on the patient's face. And then to kind of go along with that use of the inexperienced provider, the delivery of appropriate ventilatory volumes needs to be directed into the lungs, not into the stomach. While that's very difficult to isolate, or almost impossible to isolate with the use of basic adjuncts and a bag valve mask, overinflation or aggressive ventilation can increase the potential for more air going into the stomach, excuse me. So, bag valve mask ventilation. We're going to use bag valve mask ventilation with basic adjuncts. And this picture on the right-hand side of the screen, right, we've got a good CE going on. We have predominantly the 3 fingers that are applied to the margin of the jaw and not particularly on the soft structures of the neck. With this, as you rotate the bag, the ambu bag that is, 90 degrees away from you in your non-CE hand, and allow that bag to kind of drop its weight down, it helps to create a nice seal on the side opposite of the C of the right hand, for instance, in this picture. Okay. If you have the individuals, and a lot of times it's hard not to have the individuals, use somebody and attempt to do a 2 rescuer bag valve mask ventilation. Okay, especially if for those that are working on ambulances, if you have fire departments that are proactive in sending riders in with you, if they have the ability to send in 2, they can manage your whole airway without you even having to intubate. When using 2 rescuers, a 2013 study from the Annals of Emergency Medicine showed that it was just better. Better than single, and that two experienced providers doing bag valve mask ventilation, one solely focusing on the mask, one solely focusing on the ventilatory rate and volume, had predictively better outcomes than just a single rescuer. Okay. So we've done that good basic bag valve mask ventilation. We've decided we need to go a step further, be even more aggressive in how we're going to manage that airway. And then we've got to make that decision. Are we going to intubate, or are we going to apply or insert a supraglottic or even extraglottic airway? So what do you use to decide? So just take a second and kind of think on that. Is it the I can do it sort of mentality, or do you actually have a checklist that you kind of run through, and that's what you use to determine whether or not you're going to do it? And it doesn't have to take very long. Okay, so here's a quote that pretty much any medic has said at any time in their career: I need to intubate. I have to intubate. But truly, in a reflective sense, is that always the case? Ask yourself these questions. Let me back up. Why am I attempting ETT intubation, right? Endotracheal tube intubation. Am I doing it because of my ego, or am I doing it because we have tried to run our checklist of providing good bag valve mask ventilation, and we have been unsuccessful in obtaining the outcome that we're looking for in terms of ventilatory support for the patient? Am I keeping the airway open with a head tilt chin lift or a jaw thrust? If the answer is no, well, why not? And so sometimes we have to go a step back, reevaluate, and then move on to the next step. Okay? Am I using an adjunct? So it's kind of difficult to say, hey, I have to intubate right now when I haven't done a head tilt chin lift or attempted the insertion of an adjunct. Am I getting a good seal on the bag valve mask? So we've done the head tilt chin lift, looks great. We've got a good adjunct in, an appropriately sized adjunct, and now we have to ask, am I getting a good seal on the bag valve mask? Am I getting a good ventilatory effort by the person using the bag valve mask? These are the questions we need to be asking. By good effort, I mean in terms of tidal volume, rate, and quality of ventilation. Then lastly, how aggressive am I really willing to be, right? So for most, it's like, I'm going to be as aggressive as I have to be to secure the airway. And that's what we're looking for, right? We're going to be aggressive in assuring airway patency. But how far are we willing to go, and how far do our protocols, our skill level, and the personnel around us allow us to be? Okay? How aggressive can we be? And then lastly, with how aggressive can I be, what do my protocols allow, how skilled am I and my coworkers, is with all those taken into consideration, what's my backup plan? If A, B, and C go wrong, what's my D? So some advanced airway techniques again, right? Bag valve mask shows up not only in the basic, but also in the advanced. These are skills that we tend to overlook a lot. And these are the skills we should be practicing every opportunity we have to get in front of an airway mannequin. So the other ones we're going to look at is that supraglottic airway devices, the SADs, the laryngeal tubes, the ETIs, endotracheal intubations, and the dual lumen tubes. You can toss that dual lumen tube up into that supraglottic airway device, and it fits well into that little box. Okay, so how do you determine a difficult airway? I'd asked it previously. Going to take just a quick couple of minutes and look at this video concerning the use of the Lemon scale in your clinical practice. Look, with Lemon, Malin-Potty, and some of these other kind of more anesthesiologist-driven classification methods, they still have pertinence to our clinical practice in the pre-hospital setting. So we're going to take a few minutes, watch this video, we'll come back and talk about a couple other ways to evaluate whether or not someone is going to be a difficult intubation.
Hello and welcome to this month's EM Live. This month we're going to go over the lemon law for the difficult airway, also known as making lemonade out of a lemon airway. So a failed airway, what's the definition? So emergency department data estimates about 1% of patients have a failed airway. They typically define a failed airway as being unable to intubate a patient after 3 attempts by a skilled operator. I think that most of us don't consider actually that as the true definition of a failed airway. A failed airway is when we are sweating, we wish we were not the one taking care of that patient, and that we could actually be done with our shift and be at home right now rather than trying to deal with this falling apart situation. That, I think, is more the definition of an emergency physician's failed airway. I think as long as we can keep bagging, saturate the patient, we're not traumatizing the airway by our attempts and making it all swollen and harder to intubate, but we're taking it slow, we're keeping them oxygenated, we're going to our next step, which may be a bougie, it may be a fiber optic scope, maybe we're using the glide scope. I think that that's not really a failed airway in my mind. I don't think it's a failed airway in your mind. A failed airway is, oh my God, their sats are dropping, I can't bag them, oh, they're turning blue, sats are 50, I'm making another attempt. That's a failed airway. But let's go through this lemon law, which hopefully will alert us to that fact that this may be a patient who could end up with a failed airway, so we can plan for disaster, if you can plan for disaster. So the mnemonic lemon, so that's look, evaluate, Malin-Potty, obstruction, and neck mobility. Lemon, look, evaluate, Malin-Potty. Sounds like Malin-Potty is such a strange sounding word, isn't it? It sounds like a what you would call the toilet facilities in some foreign country. But anyway, I'm sure it's somebody's name and I just insulted some very important person. But anyway, Malin-Potty, obstruction, and neck mobility. No offense indicated. All right, so let's go over look. So it's always a good idea to look at the patient you're going to intubate. And I actually like that look is in there, because a lot of times when things are going crazy, we sometimes don't take the time to actually stop and just look at the patient we're about to deal with. So we're looking, are they obese? Do they have a bunch of facial hair or facial trauma, gigantic beard? Do they have neck surgery, big scar over their throat? That's never a good sign. And one that got me recently, partial dentures. I was intubating a patient, all set to go. Now, he was already kind of clamped down, so I wouldn't have been able to get in there really well anyway. But I should have thought about, could there be partials or dentures in there? And as we're putting them down to intubate, I got him paralyzed. I open his mouth, and he's got partials in, and now they're loose, and they, of course, fall back into his airway. And now I'm fishing around, and I'm pulling them out. And everything turned out fine, but it reminded me that I need to think about these things in every patient I intubate. Partials are really easy to miss, and they're small, so they fall back in the airway. All right, so don't forget the dentures and the partials. Evaluate is the E, the 3-3-2 rule. So 3 of the patient's fingers should fit into his open mouth. That lets you know that the mouth opens wide enough to get your scope in there and actually see what you're doing. And remember, it's the patient's fingers, so if you have gorilla hands, that doesn't count. Then it's 3 of the patient's fingers from the mentum, so from the tip of his chin, back to the hyoid bone, or basically the side length of the chin here should be about 3 of the patient's fingers. And then 2 fingers from the top of the thyroid cartilage, you can feel your little notch there, to the floor of the mouth, or floor of the mandible essentially, or the hyoid bone. So it should be 3, 3, 2. And that's a sign that they have good anatomy. They don't have a real small jaw or something that's going to be hard to intubate. Mal and potty, my favorite. All right, so there's 3 classes. These are always so confusing, but here's a little diagram that basically goes over it. So with class 1 is the one you want to be. Class 1, A number 1, that means everything's good. You can see their whole soft palate, hard palate, their full tonsils, and their full uvula. Class 2, you can see part of the tonsils, and you can still see the hard palate, soft palate, but now you may be missing just the tip of the uvula. Class 3, well, the tonsils are pretty much gone. You can see the soft and the hard palate. And class 4, now you only have the hard palate. So obviously as you go up in class, it gets more and more difficult to intubate. So you want to look in the patient's mouth. Then obstruction. So do they have stridor? Is there a possibility of a foreign body? Are you worried about epiglottitis? Is there something where you're worried that this could be a difficult airway simply due to something obstructing your ability to intubate? And finally, neck mobility. So obviously anybody with a suspected C-spine injury or where you're protecting their C-spine is considered to have neck immobility. You can't move their neck. You have to do inline stabilization, which I like to do by having somebody stand instead of beside me, which was initially how I learned it. You know, there'd be a person standing beside me holding the neck, kind of bent down on their knees, holding the head. And I've moved to the, I think, much better position of having a person who's standing in front of me, facing me, reaching over the patient's body and holding their head from that side. And I think it leaves you much more mobility. Then are you worried about arthritis? Are you going to pith them because they got some rheumatoid arthritis and ligamentous laxity at the top of their cervical spine? Or are they severely kyphotic where their head doesn't even hit the pillow? When they're lying there, we know those patients, they look like a big letter C, and you think, oh gosh, how am I going to intubate that person? So neck mobility. So let's go over that one more time. So the Lemon Law. Look. Oh my gosh, I'm about to intubate this patient, I better look at them. Evaluate, that's the 3-3-2 rule. Mal and potty, 1 is good, 4 is very bad. Obstruction, when I worried that something's blocking this airway, epiglottitis, and neck mobility, the letter C. Alright, I hope you enjoyed this month's EM Live. We will see you next month. Bye for now.
And we're back. Okay, so I know what you're saying. A lot of the times it's like, hey, how can we do that in the clinical setting, or how can we do that in our clinical practice? There are going to be times when it's going to be very efficient for you to do that. You're going to have a little more time to kind of pre-plan what's going on. Now, granted, you may not say like, hey, "Excuse me, sir or madam, can you take 3 of your fingers and place them in the narrowest portion of your mouth, and do they fit?" However, there are some of those things that we can kind of pre-plan just through normal interview with our patients, and we can kind of take a look, right, when we, for that, say that unconscious patient, we can take a look at them and decide whether or not, kind of using those tricks, even though we may not, or that assessment modality, even though we may not have them as a conscious, willing participant. Okay, so this slide here, right, shows the 3-3-2 that was described in the video, or in that little excerpt from the wonderful world of YouTube. So, so we see here that we've got the 3 of the mouth, and so when we do that 3, remember it's the patient's fingers, not your fingers, and that we're going to try to measure that in the narrowest part of the mouth. So maybe not here, but more kind of in that side pocket. Then we've got the next 3, right, which is basically from, you can almost consider it from the symphysis of the mandible to the where you can feel your trachea, or that larynx meet, or where that hyoid is. And then the 2, right, is going to be the distance basically from the bottom of your jaw to the Adam's apple, for instance. Okay? And again, that's the patient's fingers, not necessarily your own. Another modality that we can use is just kind of a 4D airway assessment. This is brought to light in a book by a CRNA named Rich. It's from a book called SLAM Airway, or Street Level Airway Management. If you ever have an opportunity to pick that book up, I highly recommend it. It has a lot of tips and tricks for the pre-hospital intubator, or pre-hospital airway manager. So what we're going to look at, right, we're going to look at distortion is the first D. So we're looking for airway swelling, any sort of airway trauma, neck mass. So think of neck mass kind of coincides with a rather large other portion of the body, right? So pretty much from the neck down, they're going to be disproportionate. Any sort of hematomas or abscesses, or previous surgical airways. Okay, so that's going to definitely change the morphology of the airway that you're looking at, or the difficulty, right? Disproportion, okay, is, excuse me, let me go back again. So disproportion is going to be things like the size of the tongue relative to the oropharynx, right? So you have that really large sort of cow tongue sticking in there, even through good maneuvers. May not be the best time for you to try to intubate, or maybe a very difficult intubation. And I think the point that should be made is that for those of us in the pre-hospital setting, the easy intubation doesn't exist. An easy intubation for us particularly would be in a surgical suite with plenty of hands around to help, and we would be able to have anything and everything at our disposal. 4 o'clock in the morning, wedged in between a toilet and a bathtub trying to intubate, there's nothing easy about that, right? And so it's okay to say, hey, look, it's doable. These are all difficult airways, and we need to go ahead and think about a different way to get that airway managed, i.e. like a supraglottic airway. Okay, so disproportion is going to be that, that big, thick cow tongue, decreased range of motion, particularly in the cervical spine, as you may or may not be able to line up the axes of the head and neck to be able to get good visualization of the glottic opening. And then a dental overbite, if they have a big overbite, or incisors that are disproportionately larger than the lower incisors, that tends to lead you into a difficult airway, right? These are the things you can even notice, some of them, most of them, prior to even getting all up in that patient's business, right? A lot of that you can see from 10 or 15 feet away. Okay. So advanced airway management and ventilation, as you can see, just taking these slides from Paramedic Care Principles in Practice. It's the 4th edition, the most recent edition out there. So extraglottic airway devices are coming back in favor. They are inserted blindly into the airway. There's retroglottic airways, so they're behind the vocal cords. There's that supraglottic airway, which is above the vocal cords. Most of what we deal with, at least in Eastern Tennessee, most ambulances is going to be that supraglottic airway. Okay, so something above the vocal cords. So extraglottic airway devices, that dual lumen device, right? We commonly refer to those here as the like the combi tube. Okay, the PTL's really lost in favor, and I think later on here in the slide they show one, but it's not really taught in Tennessee anymore. So you've got the combi tube. It's blind insertion. It goes into the it's designed to go into the esophagus, right? So remember that tube 1, when you ventilate in tube 1, is actually the side ports of the combi tube. It's also important to remember those contraindications for the combi tube and for the supraglottic airway, right? That King LT, the iGel, the King LTD, right? So that ingestion of caustic substances, the potential for esophageal varices, which goes hand in hand with alcoholism and liver disease, or that cirrhotic liver. Those are the things that we need to be watching out for with these supra or extraglottic airway devices. Okay. And if it's been a while since you've played with one of these, once you hit your skills session, it's not going to be a bad idea to jump on in that and get elbows deep for the review. So here's an example of a combi tube. All right. So with that combi tube, you'll notice that when we're ventilating in tube 1, we're actually ventilating here, or that's where the air is coming out. If, for instance, we end up ventilating into tube 2, that would mean that we have accidentally taken this portion, that distal end, and inserted it into the trachea, right? So we've intubated a patient. Either way, there's a lot of argument about whether or not these should be pulled or not, and it's this educator's opinion that unless you have tube failure and or you're not getting the ventilatory support you're needing to sustain or to move this patient to a positive outcome, there's no reason for this device to be removed in the pre-hospital setting. ETC placement, right? Perform optimal bag valve mask ventilation. We always want to have high concentration oxygen. And let me back up for just one moment. There's several studies out. One was actually done by UT Lifestar several years ago concerning the application of a nasal cannula into the nares of a patient in preparation for ETI, so for intubation. But this also has application for that patient that is getting is going to get a supraglottic airway or an extraglottic airway device. So basically, you would place the nasal cannula with the prongs, the curvature going as they would normally. You don't have to apply it as you would with going around the ear and then securing like a bolo tie at the neck. But basically, you put the prongs in the nose, you crank it to 15 liters per minute, and because of the pressure gradient, we're able to provide in that dead space volume we talked about previously more oxygen, and those alveoli are constantly trying to suck or trying to let oxygen diffuse into the tissues. And so some studies have shown that by doing this, with this kind of thought in mind, that for the average pre-hospital intubation, Okay, it takes greater than 60 seconds to get the intubation completed and ventilation to occur. And so that's quite a while without any sort of oxygenation. So through the use of this technique, in some studies, it's shown that it's actually kind of stretched that to 2 to 3 minutes of, it can go like 2 or 3 minutes from the temporary halt on ventilation in preparation for intubation, and has allowed the saturation levels to maintain. And that's provided that previous to all these things, we've had good bag valve mask ventilation going on, or we've had good ventilation or respiration going on with that patient prior to that, prior to these maneuvers. Okay, you want to insert it gently, right, to the depth indicated by the marks on the tube. You're always going to ventilate tube 1 then 2, right, always color then clear. And you know, some agencies have actually gone away from that extraglottic device. They're actually moving more towards that supraglottic device, the King LT or the iGel. A few may be using LMAs, but even the combi tube has started to kind of move its way out. Okay. Remember with that combi tube that as soon as you insert and inflate your cuffs, be sure you take off your syringes, that you're listening over the epigastrum first, and then should you not hear sounds in the epigastrum, right, then you're going to immediately go to lung fields. Should you hear sounds in the epigastrum, then you're going to move to the to tube 2. Okay. Let's see, the pharyngeotracheal lumen airway, the PTL. Just be aware that it's out there. It's not commonly used in Tennessee. As a matter of fact, it's been taken out of the curriculum. However, for those that are kind of taking this class as bridges to National Registry or from out of state, this may be still in use in your locale. Okay. And there's the winner chicken dinner right there. So, with that PTL, you're going to place the patient's head in a good position, just like all the extraglottic airway devices. Remember, you secure the tube first. So once you've inserted, right, you have to secure that tube down. And now we're just going to kind of jump through the PTL deal. Right. Okay. So now getting to kind of the more commonly used stuff. So right, the King LT airway is kind of the bee's knees right now, where it's the flavor of the month. Both the King LT and the King LTD are retroglottic. They are dual cuffed, single lumen, and while they don't isolate the esophagus, they do present with very good outcomes. And even for inexperienced providers, the first-time pass rates to successful ventilation in quite a few studies is in that 95% range. Okay, so that's pretty outstanding, taking into consideration the ability of the user and that there's been more than just single studies done on it. Okay, and we'll just kind of jump over the EOA because I'm not sure if many folks are even using this. So the EGTA again, just going to kind of jump over that. The supraglottic airway laryngeal tube, or the SALT airway, was pushed really hard maybe 5-6 years ago, right? Folks had a lot of really good, it was supposed to be the next big deal. Plenty of videos, particularly floating around the fire service, of people sliding these babies in on upside down, backwards, inside out patients, and it was working great. However, the studies have not really shown that to come to fruition. The SALT airway has really high success rates of insertion and use in the BLS context, right? So when you use it as an adjunct, the ease of insertion and using it such as almost like an OPA, highly successful. the ETI or the intubation application of this device has been suboptimal. One of the case studies I read prior to this was from the National Institutes of Health and the CDC, and they referenced a couple of studies done or that were published in the pre-hospital emergency care, and it showed that they were just suboptimal in the advanced setting. The laryngeal airway is a supraglottic airway. The laryngeal mask airway, the LMA, was like the first laryngeal airway. There's the LMA Supreme and the LMA Fast Track. Again, a lot of these aren't particularly used in the pre-hospital setting, at least in the eastern portion of Tennessee, which is where most folks for this class are coming from. Predominantly, folks are using either ETI, King LT, King LTD, or the Combi tube. Okay, so there's a picture of the LMA Supreme. Okay. Then there's the AirQ, the intubating laryngeal airway, the AMBU laryngeal seal, which is a supraglottic, single-use disposable airway. And then we get to kind of what we consider the gold standard. However, endotracheal intubation has been a hot topic, fairly controversial in the pre-hospital context. And so this is one of those deals where folks are getting less and less practice in. And if it's been a while, remember that, one, we have to stay proficient, right? Because practice doesn't make perfect, practice makes permanent. And there's a book out there that I highly recommend folks read. It's called The Talent Code by Daniel Coyle. And it just reiterates that fact that through studies on myelination, that learning revolves on the myelination and that we have to have practice in the proper way to make it permanent. Perfection may not ever occur, but remember this too as well, and I'm just full of sayings today, is that there's the saying that amateurs practice till they get it right. Professionals practice till they can't get it wrong. All right, so again, this is a hot button issue. A lot of medics will say they can have my endotracheal tube when they pry it from my cold dead fingers, and ironically, that may be what happens when one of us goes down, and you got 6 paramedics arguing about who's going to intubate, and none of them can get it. So anyway, it's a little side joke, but it is something that kind of should resonate in the back of your melon. Okay, so endotracheal intubation, you got to select a patient carefully, right? Like going in 4 o'clock in the morning, really rotund or obtunded patient, very little room to move. Maybe that's not the best time. Maybe we need to select that patient for one of those extraglottic or supraglottic airways. Okay. Again, we got to practice regular. We got to move early to a backup plan, right? So we need to pre-oxygenate or pre-oxygenate, right? So that one ventilation every 3 seconds with a bag valve mask, adjuncts, and a good head tilt chin lift, bag hooked up to 100% oxygen flowing at least 15 liters per minute. We want to get that going for a minute. And one of the things that I think we're really starting to get accustomed to is we've got plenty of time. As a challenge I give out frequently in classes is to have medics close their eyes and on the word go, have them raise their hands when they believe that a minute has gone by, right? And I invite you to try it at your own locations because it's amazing. Unless that medic just sits there and counts 1001, 1002, most of us aren't really good because we're so used to making rapid decisions and very tight sequence in a short period of time, and we don't realize how much time we really have to play with. Okay. So again, orotracheal intubation or oroendotracheal intubation, OETI. Patients in cardiac or respiratory arrest. The laryngoscope, I think we're pretty well versed in what the laryngoscope is, right? That's the instrument for lifting the tongue and epiglottis out of line of sight. So you can see the cords, the handle and the blade illuminates the airway, right? So you got to be light, bright, and tight. And something to consider on that, or the challenge to you now, is how often are you really checking your airway rolls, right? Are you checking that handle and that blade, or your favorite blade? Are you checking that every shift, every day, making sure that you are light, bright, and tight, that you have a backup plan in case something goes wrong, right? Those are the things that, as you progress in your career, as we progress in our professions, right? Those are the little things that carry a lot of weight, not only in building a culture of preparedness and professionalism, but that also kind of seeps itself into your own, into the marrow of your bones almost, and makes you feel more confident as you run into that call late at night with very little help, but you know that you've gotten everything prepared and ready to go. So again, it's super important. So you got your laryngoscope blades, right, curved and straight, your Max and your Millers, some new blades, the View Max, the Grand View, got some articulating tips, got that endotracheal tube, flexible translucent tube at both ends. You know about the links. So the adult tubes have cuffs at the distal end, pediatric tubes, some do, some don't. There's a lot of stuff coming out about maybe just using cuff tubes with kids. And then plastic, the stylets. I think most folks are using either stylets or bougies at this point. So here's just a picture of an ET tube. You've probably seen these 100 zillion trillion times. So just another reminder. So endotracheal intubation, continuing on. An introducer, right, the gum elastic bougie. In some services in East Tennessee, it's really hard to get these, and in others, they're handing them out like the 60-cent pieces of gum elastic that they really are. Okay, if you don't have them at your local service, after you get through with this presentation and your skills day, if you haven't tried them and seen how easily they work, if you're not sold by the end of this lecture, after playing with them for a while, you should be. They sure can make life a lot easier, particularly with those innovations that are more difficult, that are becoming more and more difficult. Okay. So again, on this one, it just shows you some equipment that you need, right? Either a commercial tube tamer or a tape, some forceps for foreign bodies, some water-soluble lubricants, and that's one thing that I think a lot of us forget to do, is kind of lubricate those tubes down. Suction unit, and then here, like the confirmation using end-tidal CO2 or an esophageal detection device, or both. Towards the end of this presentation, we'll talk about what I consider to be the 5 or 6 must-haves in terms of confirming proper tube placement, and these are no-brainers for you guys. I'm sure most of you use these in your clinical practice whenever you have to. Okay, so again, more stuff. Here's some things that get complicated with intubation, right? So you got equipment malfunction. We are less likely to have equipment malfunction if we're checking off our equipment regularly. Okay, tooth breakage. Nobody wants to break the teeth. But sometimes it just happens, right? Aspiration, elevated intracranial pressure. The hope would be that we can actually reduce that if we're going to intubate. And that's not, the elevated intracranial pressure, that's not something we're really going to be able to determine on the scene, right? Whether we elevate it or not. We don't know if, say for instance, that pupil that blows is due to what we did, or that it was part of the disease that they were experiencing, and it was progressing while we were trying to do our thing. Transport delays, we have control over most of the time. Hypoxemia, we have control over all of the time. Esophageal intubation, we have control over that as well. And endobronchial intubation, we have control over that in addition to the esophageal intubation. So those last 3 man, we have complete control over that. You'll say, no, we don't, but in actuality, we do. It would be the rarity that anyone could make a case for those three not being within your control. So some more complications, right? The laryngoscope is an instrument. It's not a tool. Okay, it's not a prying tool. It's not. It's just a piece of the device. And as we start placing this device into the mouth, right, we want to take a very systematic approach, right? Lips, teeth, gums, so on and so forth. I also think for your consideration, or I would like for you to consider in your clinical practice using the laryngoscope in that very systematic and gentle fashion in the insertion of a supraglottic airway, that King LT, that combi tube, or whatever, with this kind of caveat. If our goal is that the patient is going to walk out of the hospital, we want to make sure that we do the least amount of harm that we can. And so if we can gently place those devices into the oropharynx into position versus the traditional ventilate, orders, lubricate, and then stick it in, right? The old Vols mnemonic from EMT school. The better off we're going to be, right? And in my opinion, that's one of those things that helps us transition from being pretty good professionals to practice practitioners and professionals. A couple other complications, misplacement. Is that a complication? Well, sometimes it can be tragic, right? Potentially lethal. I'm going to argue at the slide for a minute. If any suspicious tube is in the esophagus, remove it. If any suspicion tube is in the esophagus, I would argue that if you're going to attempt for a second intubation, I think most folks will agree, keep that tube in place. It's difficult to get two ET tubes into a esophagus, so hopefully the next opening you see is that glottic opening and the vocal cords. And we all have been there at one point in some form or fashion of a tube that's gone too far through the vocal cords into the trachea, and we've done the mainstem bronchi thing. Typically, it's going to be a right mainstem. The two indicators, right, are going to be absent breath sounds on one side, and then the placement of, or the depth at the teeth, right, it'll be towards the higher numbers on the mark, maybe even 32 centimeters, depending on the size of the tube. But it may be something as slight as just 26 centimeters, right? Want to pull it back, and for most adult males and females, for most adults, right, we're going to be somewhere between 20 and 24 centimeters, okay, with some gender bias on that. Couple others. Again, if you suspect a tension pneumo, or not again, for the first time, if you suspect that tension pneumothorax or a tension pneumothoraces, do a needle decompression, right? So you can do the anterior or mid-axillary approach, right, between the second and third rib on the mid-clavicular for the anterior approach, and between 5 and 6 on the mid-axillary. And also consider when you're going to do that, if you have to decompress, that it's not going to be just a single needle, most likely, but a cluster of needles necessary to decompress that chest. Again, kind of beating the horse, but I think it's worth beating. Oral tracheal intubation technique, right, through the mouth, direct visualization of the vocal cords, clear view of the ETT's passage through them. And we're going to be talking about in just a minute some partner assistive techniques that can help us greatly increase our chances of successful first time intubation and ventilation. Some oral tracheal intubation techniques apply ELM or burp. Previously the slide had said cricoid pressure, and you can see how much has changed in even a couple of years. But ELM, or external laryngeal manipulation, or burp, visualize the larynx, insert the ETT, inflate the cuff, ventilate. And remember, we just want to inflate the cuff to a pressure sufficient to maintain the seal, right? We don't have to overdo it. Confirm placement with an end-tidal CO2 detector, secure the tube and reconfirm placement. And again, we'll talk about some techniques to do that. So some intubation assistance techniques. Number one is external laryngeal manipulation. Okay, external laryngeal manipulation is done by the use or through the is partner assisted. And so we're going to take this real quick sort of video that's been inserted into this presentation, check it out, and then we'll come back and we'll talk about the burp method, which is a form of the bimanual laryngoscopy or the external laryngeal manipulation. So trays in the upright position, right? Seat belts fastened, and away we go.
Bimanual laryngoscopy involves reaching around the patient's neck with your right hand and applying pressure on the thyroid cartilage. This simple and fast maneuver does two important things. First, the opposing forces of the blade tip and external manipulation drive the tip of the curved blade fully into the vallecula, causing effective epiglottis elevation. Second, it pushes the larynx backward into better alignment with the laryngoscopist's line of sight. Bimanual laryngoscopy, or ELM, is not cricoid pressure. Cricoid pressure is done by an assistant to prevent passive regurgitation of stomach contents in high-risk aspiration situations. Bimanual laryngoscopy is deliberately done to improve laryngeal view. The goal is first-pass success and avoiding episodes of bag mask ventilation. Fine movements of the blade tip at the vallecula and subtle changes in pressure and direction of force can cause dramatic differences in laryngeal exposure. Bimanual laryngoscopy is about connecting these fine movements at the anterior neck with direct observation of laryngeal view. After the view has been optimized by the laryngoscopist, an assistant can transiently maintain external manipulation at this location, freeing the laryngoscopist's right hand to place the tracheal tube.
All right, so as you'll see on the photo here, it's burp, also known as external laryngeal manipulation. The difference is the way we present, or I typically present burp, is through the use of an assistant, and that visualization occurs with the intubator having their right hand free, using the laryngoscope to visualize, and that the backwards upward right pressure, which is all in relation to the patient, right? So the patient's back, towards the patient's back, up towards the patient's head, to the patient's right, and then pressure. 90% of the time, best view will be obtained by pressing over the thyroid cartilage, not the cricoid cartilage, all right? So remember, cricoid cartilage is out, thyroid cartilage is in. So again, we're gonna insert another video into this one. So sit back and enjoy. Really try these in your skill stations, on your skill days. The ELM and the burp have folks that we've taught this to, which should now, honestly, at some point be fairly common throughout the area. Folks, when they remember to do it, report really good success. So see you in about 7 or 8 minutes, and we'll pick back up with another intubation assistance maneuver.
Hey, Jim Hoffman here from EMS Office Hours, and this is your Monday Minutes. Today's Monday Minutes, I wanted to just talk a little bit about a technique that you can use when you've got a difficult intubation, or maybe even a not so difficult intubation, just to further help you successfully intubate patients. Of course, in the field, and what we're trained is looking for the vocal cords, and of course, we would like to see, every time we intubate somebody, a nice, clean picture of vocal cords. This is what we want to see. But of course, it's not always the case. We don't always get to have that luxury. Airway management is one of the biggest challenges in EMS and for providers, and especially when you've got coming into question our success rates in intubation and whether or not we're performing it properly and safely. So when you have difficult airways to try to intubate, using something called this burp maneuver can actually help you when it comes to doing that. So what is burp? Well, it's a backward, upward, and rightward pressure of the patient's larynx. And what this does, this can actually improve the visualization of the structures inside the airway, and mainly, of course, the vocal cords, and it eases your intubation. So right here is just a quick little description. Again, burp, it's backward, upward, rightward pressure. Now I have a quick picture here for you to look at, just to kind of give you an idea what you should be looking for. Now backward is the first thing you want to do, and when we say backward, we're talking about pressing down towards the patient's spine, towards their back. And then upward and rightward, you're kind of doing that in the same sort of motion. So what you're doing is, again, you're putting backward pressure on the thyroid or those cricoid cartilages, and this is that back maneuver. And then what you're going to do is you're going to add that movement of the larynx in a superior motion or upward, and then you're going to displace it towards the right. So again, backward, upward, rightward pressure of that larynx. And this is going to actually wind up displacing the thyroid cartilage in a way where the larynx is going to be pressed against that cervical vertebrae and be able to go ahead and bring those vocal cords into view. Now here's another quick picture of the rightward pressure, just so you just kind of see what you're doing. Now you want to grab onto the cricoid cartilage, the cricoid ring there. You'll feel like where you would do normally, let's say, do your needle cric. Right there is where you're going to push it. You're going to push down on it, push upward, and then towards the right. And I think you're going to find that it's going to bring those vocal cords into view for you. So what happens when you do that, instead of seeing this, where you see nothing and maybe the esophagus, you're going to be able to, once you do that burp maneuver, is you'll be able to see something like this, where you can actually see the vocal cords and be able to intubate the patient safely and easily, much easily, and get a advanced airway for difficult airway patients. So I suggest you go ahead and try it the next time. Some of us might already know about this. I mean, I was at a continuing education class recently where I was aware of it, and some other paramedics in the class were aware of it, but some were not, and I was a little surprised that some of the paramedics were not really aware of this burp maneuver. And it's been around, I believe, since 1993 when it was introduced and kind of described back in 93. So again, try it out, guys. If you next time you have an airway, if you don't see the vocal cords right away, instead of playing around and poking around in there and trying to get more leverage and putting stuff under the patient's shoulders and all that good stuff, try the burp maneuver first, and I think you're going to find it a little bit easier to see the vocal cords. One thing to mention is that you can actually do this on your own as the intubator, especially if you work with an EMT partner or someone who's not familiar with this procedure. You can go ahead and do the maneuver on your own, and then just tell your partner exactly where to hold and replace your hand with theirs and hold it in place as you go ahead then and take the tube and pass it through the cord. So of course you can't do this on your own. It's going to take more than just two hands to do this, but if you're familiar with the procedure, you can go ahead and manipulate the larynx into position and then have your partner hold that position as you pass the tube. Occasionally when you do that, when you let go, it might shift just a little bit because they're not anticipating that pressure, so just adjust it a little bit to bring them back into view again for you, and then pass that tube. Of course, check lung sounds, and don't forget to confirm with end-tidal capnography. Okay, guys, that's it for this Monday Minutes. As always, visit emsofficehours.com for more Monday Minutes, for the archives of the podcast, and in addition to some other commentary articles and some training information over there as well. And I hope to see you in my members list as well. You can join the members list over at emsofficehours.com. Also, until next Monday, this is Jim Hoffman, and as always, stay safe.
All right, and so the last thing we're going to go over is bougie-assisted intubation. Again, I said previously that bougie is hasn't quite permeated through all the services sort of in East Tennessee, or the fire departments for that matter, and we're hoping, or I'm hoping, that it'll become more widely used in the pre-hospital experience. A lot of aeromedical's been using them for years. I think it's just super important to have it. I think the other piece that's important is the video that from Vanderbilt that we'll be showing here in just a minute shows kind of the single person use of the bougie. I think it's important to also teach assisters, partners, right, EMTs, AEMTs, on how to use them or how to assist not only with the bougie but with external laryngeal manipulation and burp. So check this video out. I'll see you back here in 4 minutes and 47 seconds, and we'll wrap this baby up and you can go on your merry day.
Hello, I'm Kevin Ha, part of the emergency medicine faculty here at Vanderbilt. We're going to focus on 5 things regarding performing intubation with a bougie. The first, optimally positioning yourself and the patient. The second, prepping your equipment, performing progressive laryngoscopy, passing the bougie itself, then passing the tube, and then doing a type of follow-through that we're going to show you. So 5 things in under 5 minutes. So the first thing we're going to do is talk a little bit about positioning. You don't want to be where you're looking over the patient like this, like you're looking down into a manhole. You'll know what that sweet spot is, but just take a second, and if you can manipulate the level of the patient and your relationship is same, do that. To optimally position the patient. Unless they're in C-spine precautions, get their head up in that ear to sternal notch position. Their facial plane is parallel to the ceiling. That's going to make you give you the best view of the airway. Second thing you're going to do, get your equipment ready. I'm teaching this skill on how to do this on your own. And so we're going to preload our tube onto our bougie. What I like to do is put the tube onto the bougie and have kind of an equal distance here and here. And then what I'll do is maybe then back it up about half as much. And then I'm going to grab the tail end and come around just like so. So that's what I'm going to end up with. And that's how I'm going to hold the tube and correctly place it. This allows me to intubate without an assistant. I can keep the laryngoscope in the patient's mouth. I can pass the bougie and pass the tube. This is a really vital skill to be able to do this on your own without an assistant. The next thing we want to do is talk a little bit about progressive laryngoscopy. We want to progressively view structures. Look for the uvula, find the epiglottis, put the blade into the vallecula, start looking for the posterior anatomy, the posterior cartilages, the interarytenoid notch. Start looking for that little bit of glottic opening, expose the glottis, look for the cords, progressively look for structures. The next thing we're going to do, number 3, is talk about passing the bougie itself. I try to hold the bougie about right there in the middle, this g'day tip. Not like that, like that. This is the end towards the patient. It's the easiest to pass in this fashion. The other thing it does is it gives you the best tactile feedback. Think of the bougie as like a placeholder. It's going to go through the glottic, or into the glottic opening, through the cords, kind of hold our place, and then right behind it, here comes the tube. You'll have this potential space, if you will, from the bevel, the very tip of the tube over here to the bougie. And what happens is it'll catch on that right arytenoid. If you just do a little bit of a left turn, you notice how the bevel changes, and we're able to pass it like there. So it's catching like so. We just make a little bit of a left turn. And then the last thing we're going to do is follow through. Let's do that really quickly. I'm looking for structures. I'm going to pass the bougie. I'm passing the tube. I'm right here at the glottic opening. I'm going to make a little bit of a left turn like this. I'm going to go right to 22. And I'm going to anchor my thumb right on his maxilla. I'm going to withdraw my laryngoscope. I'm going to pull my bougie out. Whether it's a stylet or a bougie, I call it avoiding starting the lawnmower, where you'll have somebody that'll really rapidly and forcefully try and withdraw the bougie or withdraw the stylet. If you have your thumb anchoring that tube, or anchoring on the maxilla and holding that tube, it'll prevent that from happening. We've covered 5 things on bougie intubation. Let's review them really quickly. Get the patient optimally positioned, ourselves optimally positioned, prep our equipment, get our bougie and tube ready, progressively look for structures. We're going to pass that bougie. We're going to keep the Gaudet tip oriented north. We're going to pass the tube, making a left turn, and we're going to do a nice follow through, keeping that tube anchored and withdrawing the bougie and confirming placement. That's 5 things in 5 minutes for bougie intubation. Thanks.
All right, and we're back. We've talked about 3 assistive methodology or methods for successful intubation. I highly encourage you to try all 3 in concert with one another, or at the very least play around with the ideas, discuss amongst yourself, particularly in your own services and on the skills days. And I think the skills days is very important because there's a multitude of experiences from a variety of different agencies throughout the state, and it's a great way to come up with sort of a best practices. So we've used these assistive methods. We're becoming more and more proficient with our ability to intubate, and now let's talk about, just real quickly, the confirming the successful intubation. First, as we intubate, the visualization through the cords. This is kind of my top 6 ways to determine the success of your intubation, right? So we're going to visualize through the cords. We're going to confirm tube fog. See good chest rise and fall on ventilation, good auscultation, and 4 good fields of the lungs, right? So again at the apices and then at the bases. And then I'm still a big fan of the esophageal detection device, or the EDD, or the turkey baster, or the bulb, or whatever you want to call it, and then the capnography. Previously, prior to the kind of the wide application of capnography, for me, EDD was sort of the standard in the pre-hospital setting. But now with the advent or the wide use of capnography, EDD can be taken out of sort of this flow or the methods for confirming successful intubation. Okay, so that's it. Hope this lecture brought some stuff to light that maybe you need to work on, maybe also brought some new stuff to use in your toolkit, and that it was just a sort of a good review for some things that may have fallen to the wayside in your own clinical practice. Until I talk again, this is the end. Have a great day. Please don't forget to check out the 3-part videos on end-tidal CO2, and don't forget to tip your waitress, try the veal.